Yeah. So can you hear me?
Hello, am I visible? Am I audible?
Yeah, yes, you're
Yes,
audible,
yes, yes,
sir.
ma'am. I think some issues. Sorry for the delay.
It's okay. So you want me to share the screen?
No, I think I can share if
Acha,
you
you can
can
share
tell
it.
me if the slides are visible. Just give me a second.
Good afternoon, doctor.
Hello, good afternoon, ma'am. Sorry. Just one second. Are my slides visible?
Yeah, we can see your slides.
Okay.
Yes, sir.
Yes.
Okay.
Yeah. Is it in slide share more, ma'am?
Yes, yes.
Yes.
Sorry for the delay. I think I was not being admitted because it said it went to my personal email and then I'm using the hospital email ID. So it said no, it's not. So then I logged it as a.
It's okay,
Thank
sir.
you. Sorry for the delay. Can I start?
So just give me a minute. I'll
Sure,
just
sure.
go live. We are already on live. So I'll just introduce our today's moderator and I'll hand over the session to you, Padmini ma'am.
Yes.
Yeah,
The
yeah.
slide sharing, will you do it, Najoti?
Yeah, yes, ma'am, I'll do it. Sir, can you
Yeah.
please stop sharing? Yeah. Okay. So, a very good afternoon to everyone. I am Mrs. Jyoti Nunsel. With Hexagon Nutrition, I invite today's our eminent speaker as well as a moderator. So, just this is our fourth webinar with a eSpen. So, I would like to thanks to the eSpen also for organizing this scientific session for the today's webinar. So, we have our today webinar, which will be going to on nutrition in the liver disease from acute to the chronic. And today we have our eminent moderator, Dr. Padmini ma'am. So Dr. Padmini ma'am, she's an head dietetic of the Apollo Hospital, Bangalore. She has a wide experience of 21 years in a multi-speciality. Uh, Hospitals showcasing a robust foundation in the clinical nutrition and exceptional management skill. Over more than 2 decades, nearly, this profession has owned a very deep understanding of the patient's care, working closely with the multidisciplinary team, with the doctors to create a professional, personalized nutritional plan for the patients with the varying medical conditions. She's been a proficient in handling the complex cases involving critical care, oncology, pediatric, post surgery, including the transplant cases, which is a very important cases, and we do have a lot of the case coming in the transplant nutrition. She is also having a very rich experience in the chronic disease management. She's been updated with the clinic advanced nutrition, clinical nutrition knowledge, and she's also been a certified in a bariatric nutrition, as well as a nutrition in IBS, diabetic educator, and counseling programs. Ma'am has done a lot of the workshops in the critical care nutrition. She has more than four national, international publications. She's been awarded as a best poster presentation in the ASUNU 2023, and she has presented a lot of the oral and the poster presentations in many conferences. We are very privileged to have you, ma'am, with on this academic forum. So thank you so much for accepting, and over to you, ma'am. Thank you.
Thank you, Jyoti. Thank you for your elaborative introduction. Thank you. This is actually very good that we are having an academic session for all our dietitians and upcoming dietitians. I welcome everybody today for our session on nutrition in liver disease from hepatitis to chronic liver disease. Nutrition is no longer considered as a supportive care alone. It is an integral component of liver disease management, influencing outcomes across the spectrum from acute hepatitis to cirrhosis and liver transplantation. Today, we will discuss practical evidence based nutritional strategies and clarify some common misconception. And definitely, our Dr. Natarajan will be talking more about liver diseases and the nutrition management on these. Let me introduce Dr. Natarajan. He is highly motivated medical gastroenterologist and hepatologist in interventional endoscopist. He is skilled in diagnostic and therapeutic endoscopy, good knowledge on general patient psychology, ability to handle diverse cases. Dr. Karthik Natarajan has been MBBS in TNMC, BYL Nair Charitable Hospital, Mumbai. He's completed his DNB in general medicine and Pune Hospital Research Center, Pune, and DNB in Gastroenterology in Apollo Hospital, Chennai. So presently, Dr. Karthik Natarajan is working as a gastroenterologist in consultant at Apollo Main Hospital in Chennai. He is dedicated and compassionate physician with good diagnostics and therapeutic skills. Received prestigious international training grant by American College of Gastroenterology in 2022. I welcome you, Dr. Karthik Natarajan, for today's session. Over to you, sir.
Thank you very much, ma'am. Thank you for the kind introduction. And at the outset, I want to thank Daphne, ma'am, for involving me in this, and Padmini, ma'am, for moderating, and the entire audience for spending your time on this Friday afternoon. I want to thank Team Hexagon. Actually, I think they've been reaching me on a number which has no signal. I'm in the basement of Apollo, so that particular number has no signal. I really apologize for that. So, and I apologize for the delay again. Without wasting much time, I'll just share my slides and we'll straight away start. So I will be presenting. I believe most of the audience are it's an astute group of dietitians and a mix of clinicians, I assume. I'm going to talk more in terms of a gastroenterologist perspective. I won't. There is a lot of assessment of liver disease before we delve into the nutrition part. So I won't go into the depths of that, although my slides do have an outline so that we can know what we are dealing with. So why should we focus with nutrition? Basically, the prevalence of malnutrition is fairly high in chronic liver disease. It's to the tune of 20 to 50%. And I'll come to hepatitis. The reason why I've kept only one slide on hepatitis is most of the hepatitis conditions are acute. Chronic hepatitis itself, we treat as compensated liver disease. Then the nutrition focus is on the same line. So I thought let's not split it. We'll go just as per the guidelines that are in place, and I'll talk to you about both. So talking more about liver disease, 20% of the compensated liver disease, which includes the hepatitis and chronic hepatitis, will have malnutrition. And if you're looking at decompensated liver disease, 50% will have malnutrition. It's as high as 80% in India. Why? Because our protein sources are deficient. We have a huge vegetarian population. We eat a lot of carbohydrates, so it's a big problem. In females, they more frequently lose fat deposits, whereas in males, they more frequently lose the muscle tissue. So there's a lot of interaction with the complication of other complication of cirrhosis, like for example, ascites. You may falsely record a higher body weight. You may not check the ideal body weight. When patients have hepatic encephalopathy, it's very difficult to feed them. Nutrition is a problem. They're highly susceptible to infections and frequent admissions, which itself increase the body's demands. So do we have a complete understanding? There's a big thing that as we age, we undergo a process called sarcopenia, in which there is lipid accumulation and cellular dysfunction at both the fat level, that is adipose tissue, liver and pancreas. Whereas if you look at sarcopenic obesity, like this is something that's very important. And the example we love to give is the obese people in India as opposed to, you know, the Japanese wrestlers who are really obese. I don't know if you all have seen them. They'll all be huge, you know, but the difference between Indian obesity and those people is our visceral adipose tissue is very high. So we'll have a lot of dyslipidemia, high levels of insulin resistance, lipotoxicity, and more importantly, because of these conditions, you cannot actually treat these patients very, very easily. It's more difficult. So if you look at sarcopenia, this is sarcopenia, muscle wasting. This is obesity, and this is sarcopenic obesity. So it's a combination of both. And sarcopenic obesity is, of course, by far the toughest. It's disease. In this, you need to lose the fat while conserving muscle. Whereas sarcopenia, you need to build muscle alone. So malnutrition per se refers to both a deficiency as well as excess in nutritional status. That is why we're talking about both obesity as well as malnutrition, undernutrition. So in addition to undernutrition, overweight and obesity prevalence has increased because of MASH. That is the new terminology for NASH, that is metabolic associated steatohepatitis and related cirrhosis. So these patients may appear to look healthy because of obesity, but sarcopenia can be overlooked. Now, there's a lot of terminology and definitions. I won't go into the depth of it, but there is a big difference between malnutrition, which is a nutrition disorder, and that leads to just altered body composition. Whereas if you look at muscle wasting, you're actually looking at atrophy, in which you will see flattening of their buccal mucosa, flattening of the palmar creases, and the loss of the thinner fat. And if you look at sarcopenia, it's in general a reduction in muscle mass as well as the function. So, for example, Arnold Schwarzenegger was Mr. Olympia for 7 times. Now, with the decreased workout sessions and decreased use of all the supplements, he is undergoing aging. Even though he has the muscle, he will have reduced function of that muscle. So this is a part on process of aging, but it is accelerated in liver disease. Next is frailty. Now, this is the most dangerous of the lot, especially in our geriatric population. There's a loss of functional, cognitive, and physiological reserve overall. So it's a very vulnerable state. So they're prone for falls, prone for infections, prone for diseases, and plus they won't eat also properly. So this is very difficult to treat. Then there's deconditioning, in which there's deterioration of the muscle functional capacity alone. And that is related more to immobility and a chronic debilitating disease. That is, for example, a young patient has a heart attack or has a stroke and is in the hospital for a brief period of time. They have deconditioning. So they are actually a conditioned body. They might be healthy, but that deconditioning, which is transient in the hospital, needs to be addressed. So whom do we screen, who, when, and how? Basically, two simple criteria. If they are underweight, that is a BMI of less than 18.5, or advanced decompensated cirrhosis, which is child PUG C status. So help you see straight away this is high risk of malnutrition. These two, you don't need to use any of your tools. It's a no-brainer. You see a gastroenterologist sending a referral to a dietitian. This is child C cirrhosis. Please help. Definitely highest risk of malnutrition. BMI less than 18.5, highest risk. In child A, child B, and in the hepatitis stage, you can do the liver-specific tools which need validation, of course. That it has been validated in many studies. You have the Royal Free Hospital Nutrition Prioritizing Tool. It was done in Liverpool and other neighboring areas. And you have a liver disease undernutrition screening tool. Now, that's a questionnaire-based thing wherein you look at nutrient intake, weight loss, and muscle loss, and fluid accumulation, etc. This is just a brief outline of the RFH NPT, the scoring system. You look at the detailed nutritional assessment. What is the most important is sarcopenia. Now, we have various ways to assess it. One of the ways is, now if you look at a patient who has liver disease, who's been advised a CT scan. Now, for example, you have a cirrhotic who wants a CT scan to be done. In such a case, the reason the CT scan will be done is to rule out a triple phase CT will be done to rule out a cirrhotic nodule, a dysplastic nodule, or even hepatocellular carcinoma, to look for the status for ascites, for portal vein thrombosis, n number of conditions. Tell them to look at the L3 vertebra and screen that area. It's the universally accepted method. You look at the psoas, paraspinal, abdominal wall muscles, take a cutoff. The radiologist will calculate and give it to you. The cutoff is 50 for men and 39 for women. And it's independently associated with a very bad prognosis post-transplant. So you need to really help these patients out. This is just a rough diagram showing that this is what they use to calculate this muscle mass. If you look at body mass assessment, you can use the tricep skin fold thickness, the mid-arm circumference, the muscular area, the DEXA. You have bioelectrical impedance analysis. You can look at the contractile function, which is the hand grip strength. Very easy. It's done in our outpatients. We have the hand grip meter, and you tell them to just squeeze. Simple, inexpensive, and effective. We have cutoffs for the Indian population. And this can be done by a technician alone. So, you really don't need to do much. This is the tricep skin fold thickness, and this is the BIA machine. So how do you measure frailty? Simplest way is, you do a timed walk. You tell them to walk for 13 feet, make them stand up and down from the chair 6 times, make them do a balanced walking test, and look at the 5 domains, which is unintentional weight loss, exhaustion, weakness, low walking speed, and low physical activity. Of course, you also have global assessment tools, which is subjective global assessment, and the RFH tool, which I have said. The RFH tool, apart from the NPT, which is nutrition prioritizing tool, you have a global assessment as well, in which based on the BMI and mid-arm muscular mass circumference, You'll characterize them into adequately nourished, moderately nourished, or severely nourished. And then you take a reported dietary intake from a dietary questionnaire where you can ask them on the type of food, fluids, supplements, the number of meals, the timing of the meals, the calorie, the protein intake, and there will be barriers to eating. Why? These are liver patients. More often than not, they will have nausea. Hepatitis will have nausea and vomiting, may have fever. They have infections. They have altered taste and dysgeusia. Low sodium diet if they have ascites, early satiety because of the pressure, because of the ascites, pain, diarrhea because of the fact that they have hepatic encephalopathy, we may be putting them on a laxative, constipation. So you have to address all these factors and then try to give them meals. So you have many ways of assessing them. Again, you have some scores for that. You can do a recall. Recalls are more practical on a day-to-day and clinical, at the clinic level. You can ask if none of that is there, just ask them, has the food intake really changed? If yes, ask the percentage. So how much is the change in the appetite? What is the weight and what period of time? And that's how you need to assess them. Moving on to how you manage them, just talking about general hepatitis, acute or chronic, we talk about protein. We want a minimum of 1 to 1.5, preferably 1.5 gram per kg of protein. You have good vegetarian sources of protein as well as non-vegetarian sources of protein. I'm sure you all are better at that than me, so I'm not going to really address that part. I'm only going to talk guidelines here. Carbohydrates, as far as possible, include complex carbohydrates. Fats, limit the trans fats, healthy fats, avocado, use olive oils for this brief period of time. Hydration, 8 to 10 glasses of water at least, which comes to around 3 liters of water a day. IV fluids, if it's acute hepatitis associated with nausea and vomiting. Micronutrient supplementation is a must because acute hepatitis, the body demand increases, so does the micronutrient demand. So this is where I think the role of dietitians really comes through. Micronutrients are often underlooked or overlooked in hospitals, especially by the clinicians. Moving on to obesity in cirrhosis. Now, increasing prevalence of non-alcoholic or MASH related cirrhosis. So you call it sarcopenic obesity, as we said. Look at the BMI, it will be more than 30, even in the absence of any fluid. So how do you correct and calculate the ideal body weight? If there's mild ascites, you subtract 5%. For moderate ascites, 10%. For severe ascites, 15%. And if they have pedal edema, add another 5% for it. So the risk of histological progression of cirrhosis or decompensation increases by 14% for each increase in the BMI quartile. So this is very, very, very important. In fact, this was a landmark trial which actually told us the importance of nutrition in liver disease. The EASL recommendations are very clear. You do a rapid nutrition screen for all cirrhotic patients. Like I said, low BMI, child C, no-brainer, high risk. In obesity assessment, try to find the ideal or the dry body weight. Look for sarcopenia, look for the muscle mass, look for muscle strength, dietary intake by trained personnel, which will include our dietitians. And then this is the way we approach the flow chart. Like I said, you do, if the BMI is low or if their child C, they straight away go into high risk, you can assess for sarcopenia, treat for sarcopenia, nutritional supplementation, follow up at least every 1 to 3 months in the first year. Once they reach your targets, then you can work on them. If they are medium or low risk, then you do not have to assess for sarcopenia. Just look for malnutrition or no malnutrition and assess them periodically at 1 year. If the BMI is high, you need to give them lifestyle changes and nutritional assessment and consider looking for sarcopenia even in these individuals. So what is the problem of accelerated starvation of cirrhosis? These are the problems that we face as clinicians that we can tell them, take it. But what are the problems that we face? Altered taste, salt restriction, anorexia, portal hypertension, altered gut mobility, protein losing entropathy. There are a lot of myths. Biggest problem in India is the myth. If the moment they see jaundice, they'll restrict the protein intake, restrict jaundice. Restrict non-veg food, restrict anything that's yellow, containing haldi. Basically, all they'll do is they'll have raw salads, which will increase the chance of getting more gut infections. On the other hand, increased total energy expenditure will be there. There'll be food-related thermogenesis as well as increased energy expenditure related to the physical activity. What about the energy and protein requirements in CLD? It's definitely increased because it's a state of accelerated starvation. I won't go into the depth of it. Protein synthesis is reduced, there's proteolysis, gluconeogenesis. So your energy expenditure is very, very high. And these are the reasons that we stated. GI bleed is an added problem. So the energy expenditure should be measured with a doubly labeled water or in a respiratory chamber. That's not feasible. So in CLD patients, you should consider it as between 28 to 38 kilocalorie per kg body weight per day. Rather than measuring, we have a standard rule of thumb, which is around 30 and or 35 if you want to keep the upper limit of normal and then calculate it. The ideal is to supply 35, like I mentioned. So how do you reduce the intervals of feeding? Frequent meals, 3 main meals, which is breakfast, lunch, dinner, 3 snacks, which is mid-morning, mid-afternoon, and a late night snack. So something that was added in our guidelines was a late night snack. If the patient says I eat at 8 o'clock and I go to sleep at 10, you want to sleep at 10, no problem. Right before you sleep, we don't care if you get acid reflux, you're going to eat a snack because there will be a nocturnal fasting period. If you're into the habit of sleeping for 10 to 12 hours, well, then wake up at night. We don't care. Wake up at night, lose your sleep, munch, and go back to sleep. And the breakfast should be high protein. The late night snack shortens the fasting period. Recommended protein intake is 1.2 to 1.5 gram per kg per body weight per day to prevent loss of muscle mass. Now, what if they have ongoing proteolysis? You've got to increase this demand to 2 gram per kg. Something very important, prior to the guidelines in hepatic encephalopathy, we used to restrict protein intake. We used to say, okay, this is a state where proteins can lead to increased HE. That has been debunked. No reduction in protein intake. If you really want to go by the guidelines and the dietary advice, you want to follow vegetarian protein, that's okay. But we know that even non-veg protein is not going to really harm you. Factors related to sarcopenia in CLD, we know there are multiple. I stated that in previous slides as well. There's a lot of problems like age, gender, etiology of the liver disease, photosystemic circulation changes, skeletal muscle ammonia, reduction in testosterone and your growth hormones, which actually boost muscle, reduce dietary nutrient intake, and molecular level changes. So these are our targets to improve muscle mass, apart from the obvious, which is transplant. But to get there, you look at myostatin antagonist, which is something new, branched chain amino acids, structured exercise program, wherein we say don't do cardio alone, but do weightlifting as well, or do weights as well. Then mitoprotective agents, we do give antibiotics to alter the gut-brain axis, and hormone replacements, which is still in trial here. So optimizing the daily energy intake to 35 kilocal per kg, optimal protein, late evening snack, branched chain amino acid supplements, and leucine enriched amino acid supplements, especially when the intake is not achieved by oral diet. There should be a period of enteral feeding for those unable to achieve adequate oral diet. Avoid hypomobility and progressively increase the physical mobility. If they are obese, look at progressive weight loss, not something too random and too rapid. I see this very often with the advent of the newer molecules like tirzepatide and semaglutide. Though they are very useful for our fatty liver patients, it has still not been licensed for the chronic liver disease patients. So, there are people who say, we can use, I do have experience in the early stages and stuff like that. Well, you may have, it's still not made its way to the guidelines. Weight loss should be very slow, very progressive. They should not have a rebound yo-yo pattern and go back up to the stage 1 where they began from. Go to a slow and steady hypocaloric diet, but at the same time maintain a high protein diet, which is 1.5 gram per kg per day. So micronutrients definitely depends on the etiology. If you're looking at a cholestatic liver disease, you're looking at A, D, E, K vitamins. If you're looking at alcohol, you have to supply thiamine as well. So it can affect the reserve, it can affect the dietary intake, malabsorption, other vitamins, which are the water soluble ones, which is B1, B6, B9, B12, especially in vegetarians in our country, sodium, calcium, iron, magnesium, zinc, selenium. There's a lot of things to go through. Now, administer micronutrients and vitamins in confirmed or in clinically suspected deficiency. Assess the vitamin D levels in all CLD patients and predominantly, especially if they have cholestatic liver disease, supplement them if it's less than 20. We know that 20 to 30 is insufficient. Even if they are less than 30, we give supplementation. Vitamin K has to be given in all cholestatic liver disease, thiamine for alcohol-related liver disease, zinc supplementation. But we know that the role of zinc in HE is a bit doubtful. Selenium in hepatitis C. Avoid manganese in the diet in hepatitis E because there is a theory of manganese deposition in the basal ganglia. For ascites with sodium restriction, the recommended intake is around 2 gram, which is equal to 5 gram, 2 gram sodium, which is 5 grams of added salt per day. That's just to improve the palatability. So you need to know that HE occurs more often in malnourished CLD, which is why nutrition actually can delay the onset of hepatic encephalopathy. And it helps in muscle regeneration as well. So they can actually delay the onset of transplant. So you should remember that in the energy requirement in cirrhosis and hepatic encephalopathy is the same whether you have HE or not. HE period patients need to avoid prolonged periods of fasting because there's a bigger buildup in these patients of ammonia as well. They have the same nitrogen requirement. Type of protein is very important. Vegetable is definitely better tolerated than non-veg. Current guidelines say you can give non-veg as well. Advantage of vegetable protein is a higher fiber content, both prebiotic and laxative properties. Reduced branch chain amino acids is detrimental, and L-leucine can be given. Of course, we don't give a BCAA in advanced stages, especially if they have CKD. Just a second, apologies. Hello, sir. Sir. Okay. Okay. Sorry, sir. Okay. No problem. You take it. Will do. Okay. Sorry. No issues. Okay. Sorry. Apologies again. So in grade 3 and grade 4, the patient will be practically bedridden and comatose. So they will be either on a Riles tube or parenteral nutrition may be given. They may be on peg feeds, on nasojejunal tubes. So here you have to supplement enterally more than parenterally. I see it very often that parenteral nutrition patients have a very high frequency of infections. Avoid protein restriction in HE. In short, give a high protein diet, encourage vegetable protein diet and dairy protein. PCAs in those who cannot maintain the nitrogen intake. Oral is definitely preferred unless you have advanced HE. Cirrhosis with bone disease, basically if you have hepatic osteodystrophy, be very careful because you need to treat for osteoporosis as well and osteomalacia. So they need vitamin D, calcium supplementation, and they may need a bisphosphonate also. The overall prevalence is very high. The fracture prevalence is very high because of the vitamin D and liver cycle. So we frequently advise DEXA scans in these patients. We in fact see pathological fractures even in those who don't have symptoms. So this is just how we manage the patients. In short, calcium and vitamin D supplementation is very important. So EASL basically recommends to evaluate bone mineral density, checking the DEXA scan periodically. What's important for this talk is calcium supplements, bisphosphonates, and hormone replacement therapy. So testosterone and venesection in males with hemochromatosis and hypogonadism. But be careful that testosterone can increase the risk of hepatocellular cancer. So you need to give it under supervision with an endocrinologist on board. Preoperative nutrition for liver transplant and liver surgery. If you're planning liver surgery in these patients, severe malnutrition, severe obesity is associated with poor surgical outcomes. And sarcopenia is an independent risk factor. So definitely we need to address it. The goal is very simple. Preoperatively, if the goal is maintenance of the nutrition, you target 30 kilocalorie per kg per day and protein of 1.2. If the goal is improvement of nutrition, which is in our cirrhosis patients, in our hepatitis patient, target a higher energy intake and protein intake, which is 35 and 1.5. Utilize standard regimens which are in place. Give branch chain amino acid supplementation. Immunonutrition still does not have any benefit yet. Post-operatively, what do we do? After liver transplant, parenteral or enteral nutrition can reduce the time on the ventilator. It reduces the risk of infections, complications, and ICU stay. So we want early goal-directed therapy, early mobility. So what do? We advise early enteral nutrition in these patients. It helps the gut-brain axis as well. Disturbed glucose metabolism, insulin resistance is seen post-op. Hence, please give enterally as far as possible. The long-term liver transplant survivors, there is a problem of metabolic syndrome. It has a lot to do with the medication being used. We use a lot of tacrolimus, everolimus, which is mTOR inhibitors. We use a lot of immunosuppression in the form of steroids. They require periodic antibiotics. They do have limited mobility and they have a sudden gain in appetite because of these medicines and diabetes also. So they get metabolic syndrome. So what do you do after liver transplant? You advise normal food, enteral tube feeding within 20 to 24 hours. Whenever oral is not possible or enteral is not possible, give parenteral instead. If acute post-operative phase, target high protein and higher energy requirements. If surgery is done other than liver transplant, that is, you do just a gallbladder in a sick patient like this or a hernia surgery in these patients, you just go for the ERAS protocol, which is enhanced recovery after surgery, which is early mobilization, early enteral feeding. It will reduce ileus as well in these patients. Obese patients, reduce the TE, which is to 25, but target protein should still be 1.5 gram per kg. What about nutrition in the critically ill chronic liver disease patients, which is like acute on chronic liver failure, acute alcoholic hepatitis? Alcoholic hepatitis differs from other hepatitis in the sense that they are bordering on cirrhotic and they can anytime get an organ dysfunction which moves them into ACLF. And our lab tests, our scans may show erroneous reports as well. What do we do? Tight glucose control, supplement dietary intake with enteral or parenteral nutrition, ensure the TE is 1.3 times the measured RE. Ensure daily protein intake of more than 1.2 gram per kg. I told you in acute hepatitis, you can always give 1.2 gram per kg. Critically ill with HE, consider adding BCAAs and avoid PEGs in cirrhosis unless they are very well compensated with a high platelet count of minimum more than 1 lakh and a normal or an INR of less than 2. Nutritional support in GI bleeding. The problem is the blood flow in these patients is altered because of the portal hypertension. If they have bleeds, it alters the absorption of nutrients. NG tube we know is not contraindicated. We withhold enteral nutrition only for a brief period of the bleed. After that, the first thing we start is enteral nutrition. We usually do not advise parenteral here. What about immunonutrition? Now, these are very specific nutrients which is to modulate the immune system. It has been proposed in many conditions, but we have seen that it really does not improve renal function. It in fact increase the bleeding time in post-op patients, and it's advisable not to use them. So I'm not going to go into the names of this, but these are basically formulas with omega-3 fatty acids, arginine, glutamine, nucleotides. Parenterally they are given. There is no role in these patients. These patients already have a very high financial burden. We cannot give them something which has no proven benefit. What do we give as general instruction for patients? Something that I didn't add here, I'll add only in the last. No alcohol of any form. Alcohol, even socially, if they have hepatitis or if they are, this is a toxin in any given dose. Socially, I had a death in the family. I had a love failure. I am celebrating the 120th year of my grandparents being alive. Doesn't matter. Don't drink or you will die. An adequate number of calorie and protein is a must. Split your food intake into 3 main meals and 3 snacks. Very important. The late evening snack or the late night snack is very important. Fruits and vegetables for fiber to reduce chances of HE. Try not to add too much salt to your food. Very, very difficult in Indian patients. Easier in the West because they use salt for flavoring and not like us, salt for everything. A limited proportion of patients with liver disease actually have the complication which is HE that can alter their, they may tolerate animal protein not as well as vegetable protein. Give them veg protein and then transiently you can move over to animal protein after that. Some patients with liver disease have other issues like overweight, obesity, which requires adjustments. So please, whatever was mentioned, obesity means hypocaloric diet, but high protein supplementation. This is very important. Avoid alternative medicine. Alternative medication in all liver patients is only harmful. Alternative medicine in the form of Ayush, Ayurveda, Unani, Siddha, homeopathy never ever cured a liver problem. Never. There is no proof till date until a randomized control trial comes Never ever advise your patients to take it. No Live 52, no Himalaya product, nothing. Just basic medication, treat the disease, aim for good nutrition. With that, I'd like to thank all of you for a patient listening and end my talk. And we can probably open it up for a discussion. Thank you so much.
Thank you, Doctor. It was really elaborative and very informative session we had today. You really got into definitely on malnutrition and protein restriction generally not recommended, and especially even in hepatic encephalopathy. And your guide, whatever the guideline says, you have really covered everything, each and everything in liver nutrition management. And definitely, you spoke much about nutrition therapy, liver disease, and bone health, which usually nobody talks about it or take care about it. So that is equally important. And it was really good, informative session, Doctor. I just want to take few the questions which was there on the chat.
Yeah, please.
So they say that they want to know about what are the future lines of research regarding end-stage liver disease and post-operative nutritional intervention.
Okay, so I think very good question. So what we are looking into now is gut microbiome assessment. The problem is, I think we are overusing probiotics. Okay, it's a
Yes.
$1 trillion industry, and when you've crossed $1 billion and you move to $1 trillion, you have a
Yes.
lot of what do you say? You have a lot of money to spend on more research. So the
Yes.
moment that happens, they do a lot of this. The problem with our gut microbiome is it's more specific than even our fingerprint. We know that two twins can have monozygotic twins can have the same fingerprint. There are some beautiful movies on that. But even though two twins will never have the same gut microbiome. So what are we aiming with the gut microbiome? We are aiming to reach targeted therapies based on the gut microbiome. The problem is we cannot analyze trillions of bacteria yet. We have not gotten there. But
Yeah, but
metabolomics and metagenomics, I think the future is
future
to
is
treat
on
the
that.
patient based on their gut microbiome.
Gut
I think
microbiome.
that is definitely going to be there. And the patients who will benefit the most are these liver disease patients. If we can actually reverse the disease or prevent progression just by altering their gut, it will be beautiful. We now
That's
know
true.
that when you assess the gut microbiome, if it's Akkermansia, which is deficient, supplement that. If it's Saccharomyces boulardii, give that. If it's Lactobacillus, give that. So we now know that we need not give a garden variety probiotic, which is over the top expensive, and then the patient says, I've not got results enough. So you can use that for catering to or tailoring the probiotic, but definitely it's not, we have still not got completely there yet.
Yes, I think this is the most important topic that the research requires on probiotics, and especially in probiotics and in liver disease and in critical care also. So as we move on, and there is one more question on protein induced by vitamin K absence or antagonist 2. So
Yeah,
should
should it be
yeah,
incorporated into
incorporated
nutritional
into
assessment?
routine nutritional
No,
assessment
it's got
and
nothing to do with the nutritional assessment. It's actually PIVKA2 is a marker of liver tumor, which is hepatocellular cancer.
yes,
15% of the patients who have hepatocellular cancer. So the diagnosis of HCC is based on radiology on a very specific guidelines of, they have an early washout after an early contrast uptake. And sometimes there's a lot of, there's a lot of a gray zone over there that, it's not seen very well, or there's not a classical, washout, and you do see a portal vein thrombus where you suspect it. Then you say, okay, let's also look at the alpha fetoprotein. So alpha fetoprotein may even be normal, 15% don't produce it enough. So their PIVKA actually helps you. It helps in the diagnosis. And the Mayo Clinic, they use a composite score of PIVKA2 and alpha fetoprotein along with the MELD score to actually calculate the patient's prognosis as well. It's not recommended for nutrition, definitely. So I can actually go through the list of questions. Can I just take it
yes,
up
yes,
later?
yes, yes, yes,
Yeah.
please.
What are the recommendation of dietary fiber in liver disorders? So I didn't touch upon this topic. The reason is that when you look at liver disorders, The guidelines just say fruits and vegetables, and that's why I kept it in the last slide as a take-home point for patients. The reason is that you can take plenty of fruits, vegetables, and dietary fiber in the natural way, but the reason we don't really push that upfront in the diet chart is because what's most important is protein, protein, and protein. Only these three things. We tell them that you need three things for you to improve your survival, and all those three are protein. The reason is that's what improves sarcopenia, that's what improves survival. And the moment you have high protein, it comes at a cost of low fiber. So very, very good question. But what the problem with fiber is, it's associated with carbs only. You don't get fiber with protein. So what we do for these patients, we tell them you can take a cut fruit, you can take vegetables. Fruits are fructose, it leads to a higher spike in sugar. Vegetables would be something better. Now, in Indian patients who are vegetarians, most of the Indian patients, we do have vegetables in our diet. So that is okay. But in liver disease, more so, if they have cirrhosis and their child B or child C, we are trying to prevent hepatic encephalopathy. So more or less, they are going to be on a laxative to prevent constipation, in which case we really don't care about the fiber. So that is the reason I didn't put a specific slide on that. I apologize for it. If poor intake, shall we start TPN or only amino acid IV? Okay, so I would like to reiterate here that TPN or amino acid IV is never an option for patients with CLD unless they are unable to tolerate orally. For example, the Ryle's tube is not staying in place. The center is not having a gastroenterologist who's able to establish an enteral route of feeding in the form of a PEG or any other enteral route. TPN and amino acids in a cirrhotic have, and this is studies based, they have a higher risk of infections. And this infection, an infection in a cirrhotic can be life-threatening. You know, you just started in 2 days, the patient will just collapse and die on the spot. We just cannot do anything despite the best antibiotics because it is a bloodstream infection. So once they already have a liver damage, so one organ damage is there. The moment they get a second organ damage, the chance of mortality goes up from normal 20% in a cirrhotic to 50%. And the moment you have three organs, which is in ACLF grade 3, the chance of mortality is to the tune of 80%. So enteral nutrition as far as possible. You can put them on 24-hour enteral nutrition. Doesn't matter. Right around the day, you put an infusion. But avoid IV. Omega when in
Sorry,
CLD.
doctor, can I just ask one more question regarding this? So do you think like, it's the full, all three, the major nutrients, whatever, the three-chambered bag TPN you're talking about, or it is only if they are giving only as omega when or
No,
only
so
as
my
fatty
thing is like
acids
this
or
over here that
anything?
ma'am, as far as possible, so definitely omega when and the amino acid part is more beneficial to these patients. Um, the thing is how we base our protein intake to 1.5 gram per kg. Let's say it's a 60 kg individual, and you're giving them rice tube feeds, and you mention high protein feed.
Protein,
Egg
yes.
whites will be given through that. They will give protein powders. In addition to this, we will be giving maybe whey protein supplementation as well. Now, 2 scoops of whey protein itself is 50 grams. If we give 2 scoops twice a day, it's 100 grams. In addition to this, if they are on a rice tube intake of a high protein diet, they're going to get more than 150 grams of protein. Now, let's
Yes.
assume that 50 grams are not going to be absorbed because of the portal hypertension. Still, 100 grams is matching the person's requirement. So we really don't need any other amino acid supplementation. If it has to be given, again, oral branch chain amino acids first and then only TPN. In TPN, definitely the IV amino acids and protein first and then the general carbs bag. So that, like you said, the triple bag that we use post-op, in the
Yes,
immediate post-op period.
it has fatty acids also.
Yes, in the
Yes.
immediate post-op period, it's definitely useful. I had mentioned that in one of the slides that for the post-op, you can use it,
Post-op.
but
Yes.
in a routine admitted patient, no.
So the same question I think one or more person has
Yeah,
asked
that I
about.
think
I
we
think
have
we have
addressed
cleared.
that part. Yeah.
Omega-3 role.
So role of omega-3, yeah. So omega-3 is definitely beneficial as far as hepatitis patients go. If they have to take supplements of omega-3, I don't think so. I think through natural diet. Omega-3 supplementation, I think what you can advise is the healthier options like avocados and, the virgin olive oils and this for the temporary period of the hepatitis resolution. But in general, even for CLD, that applies even to cirrhotic patients. for the healthy fats. But I don't think we supplement with omega-3 separately because we know that the branched chain amino acids is what has improved survival in these patients. Albumin role, yes, I'll address that because there have been trials for that. There was a landmark trial published in Lancet which said that IV albumin supplementation in these patients actually proved beneficial, and it delayed transplant. So if you have a child B or child C, the moment they have the onset of ascites, you move them to one albumin twice a week in Indian standards, but actually what's recommended is twice weekly albumin. Problem with albumin is the cost, but we know that albumin improves the survival and delays the onset of transplant, or it can buy you time. It is used as a bridge to transplant. So IV albumin definitely proven.
Okay, I have one more question, doctor, regarding the sodium intake
Yes.
in liver disease. So even especially in critically ill patients. So
Yes.
what is your take on sodium intake?
Yeah. So see, as far as liver disease is concerned, ma'am, if they are child A or if they have hepatitis, what we do
They'll
is we
have
tell
fetal
them.
hypertension also at that time. Do you think that we have to do sodium restriction?
No, so the role of sodium restriction begins only and only for ascites and edema. So the moment they have pedal edema, you tell them now is the time for you to restrict your salt. What I do is, even if I see a compensated cirrhotic patient, I see a chronic liver disease, his child A, his fibroscan is high. It's proven on CT as well, maybe. We have screened for varices, we have done everything. I tell them start restricting salt now. Why? Because we know that the natural history of CLD is that if not now, within 10 years, he's going to decompensate for
Yes.
whatever reason, progression of the disease, or he may take alcohol, he may go and take some alternative medication, he may take some herbal and danger, or he may just get an infection, get unlucky, whatever, or just the natural progression, 10 years, sometime. And when that happens, if you tell him to restrict it, then no, the problem is any which ways he's not feeling like eating, he'll say, give me salt. So restrict it the day you see the patient in your OP, you should tell them start your salt restriction from today.
Yes.
If they have child B, child C, if they have ascites, definitely we do the 2 gram sodium or 5 gram salt. Very difficult to do. The easiest way, what I suggest the patient is, you don't know how much, it's a pinch. If you can afford the 1 gram salt packets, do it for each meal. For the snacks, just avoid it completely. And what I do is otherwise buy one packet, weigh it, and this is the amount you have to use always. Keep it in a transparent packet. You can do that also. One packet doesn't really cost. So I think this is what we do for sodium.
There's one more question regarding protein restrictions for CLD patients with ESRD.
Yeah, so I think this is something where we have an overlap with the renal transplant and the nephrologist over here as well. Now, the best part for us, what actually happened is that our transplant surgeons who do liver transplants also do kidney transplants. And,
Yes,
they
that
are very
was
clear
dual
on this
transplant
matter.
will happen.
It
Yes.
will happen many times. You see, what actually happens is, renal transplant surgeons. So if you know a transplant hepatologist or a gastroenterologist who's a surgeon who's done transplant hepatology and he's moved only into doing liver transplants, that's a different case. But those surgeons who do liver and kidney transplants or the simultaneous kidney liver transplants, they're very clear on this matter that the protein restriction. If you see these end stage renal patients, right, they're already
Yes,
on
yes.
thrice weekly dialysis. It really doesn't matter when you give them protein. They're already, in fact, if they have dual disease, their burnout of protein is even higher. If it is a kidney disease, they're going to have proteinuria in addition to this. Very high protein diet, not even 1.5, maybe even higher, no restriction of protein. So there's no question of restricting protein if they have end-stage renal disease as well.
Yes, of course. We have to supplement them with more
You have
protein
to.
at that time.
There's no role.
So
Yes.
at least we can target up to 1.2 to 1.5 gram
1.5.
per kg
Definitely,
body weight.
definitely,
That is
definitely.
what. So is there any fluid restriction necessary for every patient who has ascites?
No. So salt restriction for ascites, yes. Fluid restriction only if they have hyponatremia. Otherwise, no. If the blood sodium levels are low, only then you have to restrict the water intake. Otherwise, you don't.
Yeah. What is your take on refeeding syndrome with liver disease patients?
Yeah, so see, refeeding syndrome is only after a prolonged malnutrition, or if they're
Malnutrition.
not. We do see that here, unfortunately, because there are hospitals which refer these patients over, and where where they've botched up the case by not giving early enteral nutrition. 5 to 7 days they've starved the patient. In these
Yes,
cases,
for
we
many
do.
procedures, they would have kept
They would
NPO.
have. I always involve the dietitian. I check the electrolytes round the clock. I involve even the nephrologist for the correction part because they need very frequent monitoring. They are, at high risk of going into this hypoglycemia. They have a folate trap. There's a lot of problems that you need to assess. So I tell the dietitian for a daily review. We change the diet day by day. So that's how it works, in fact.
We need to check their electrolytes first and then start the
Definitely.
diet actually. And we have one more question on MSLD. Patients can go intermittent fasting and GLP therapy.
Yes, so MASLD patients, yes, they don't have liver disease means definitely they can do intermittent fasting, as long as the protein intake is taken care of. And GLP therapy, yes, it's been approved now for MASLD, can be done.
And one more very good question from our Dr. Krishnan Sriram. So he is one of the best surgeon, and in his pen, what we have been hearing about his talks and many the sessions, the cost of albumin is 10,000 for 20 grams and rupees 20,000 a day just to correct a
No,
lab value
I
not
was very clear.
indicated
We
disease.
don't target hypoalbuminemia. All right. We are very clear. The answer trial, which is what is published in Lancet, is very clear. We don't target the albumin levels. We give albumin only in patients as a bridge to liver transplant, or in those who cannot afford a transplant, but they can afford albumin to delay the onset of end-stage liver disease and death. That we are very clear. There was also a marked trial in which they added midodrine and albumin, where again we know that targeting an albumin level of about 3.5, this was published in NEGM as well, that you target an albumin level of 3.5, no role. We don't treat a value because there are so many confounding factors which affect the albumin value. Acute phase reactants, infections, leaking protein and albumin in the urine. It is not a value we target. We give albumin only, like he said, mentioned very clearly, during large volume paracentesis to prevent
Paracentesis.
the for the overload state, and as part of the liver transplantation protocol we also use it in, I told you, in patients who cannot go for the transplant, but you have a 75-year-old gentleman, they can afford albumin, nobody is going to touch them, or 80-year-old, you can delay the onset of transplant with albumin. How much protein intake per body weight given in NAFL or NASH grade based? So I think I mentioned this in my talk. I give 1.2 to 1.5 gram per kg.
Yes. Shall we wait for a few more questions, doctor?
Yeah, sure.
Any specific like in specifications on dairy proteins? Because nowadays we see a lot like about lactose intolerance or all such things. Even if they are not lactose intolerance, they said that they don't take milk or they don't want to take dairy proteins and everything. For such patients, what do you advise? Because
See, actually,
vegetarians, like it is very difficult for them to to match with the proteins.
correct. So we do have vegetarian protein and plant protein available now. Dairy protein is just part of the guideline. After that, we have had a few studies which have shown that even non-vegetarian protein can be given in HE. I think the dairy protein concept came up only because of the initial thought process of vegetable protein being better tolerated than animal protein in hepatic encephalopathy states. In which case, if in the intolerancy, vegetarian protein, the problem with dairy protein, you look at tofu, tempeh, whatever you're looking at, is very, very unpalatable. difficult
Yes,
to
that's
take.
true.
The volume required is very, very high, and the patients feel satiated very, very high.
Bioavailability is also
This bioavailability is also a problem. Nothing is
also
as good as egg, right? So the
yes.
problem is that the best way to supplement for this is plant protein. You do have plant protein powders available in plenty now, in fact, and the volume, weight per volume is pretty good as compared to this. So I think their supplementation, especially in the vegetarians, I tell them that if you cannot eat 4 cups of your pulses and soya bean as well as rajma and other things every day, they say we can't do it every day. I said then move on to supplementation. There's no other role. There's no other way you can do it. So because
Yeah, when we
many
talk
patients
about
suppose that.
such beans or anything intake of these,
Correct.
they
They
say
get
about
bloated. They say that I
bloated,
can't eat the
gaseous, and
same thing again and again. You're not allowing me to have it with salt. I want to add pickle to it. We get various kinds of responses from them. So the moment they say vegetarian, I said that's the limiting factor from your end. The limiting factor from my end is you have to take the supplement. There's no other way out.
that's
Uh,
true. That's
yes,
right. That's a common question of every patient when we talk about
100%.
proteins. Yes, there is one more. When ammonia is high in DCLD, how much protein then? I think
So,
we have spoken
ammonia
about
has nothing to do with the protein. The moment you have a decompensated liver disease, the ammonia levels will be very high. There's no prognostic role of the ammonia. It can be 200, it can be 80, it can be 150, it can be even 300. So, high ammonia levels are associated with higher hepatic encephalopathy. So, the protein remains the same, which is 1.2 to 1.5 gram per kg. It's not going to change. It's the same. There's also a question, can we give any protein supplement instead of albumin? Yes, definitely. See, the thing is like this, that what actually has been shown in these trials with albumin is that albumin is the main component of the oncot that maintains the oncotic pressure in our blood. So it prevents the third spacing uh, of the fluid. So what we are actually doing by giving IV albumin is we are reducing the needs of repeated large volume paracentesis. We are preventing the need of, we are actually supplementing a good oncotic pressure. So reduced kidney dysfunction. We can at the same time give a small dose of diuretics. These things actually are the main target. So protein that you're taking orally will never get to that level because it's not IV. Yes, the role is you keep the protein so high that you don't need albumin at all. That's the only thing we can get through. But you cannot say that take protein instead of the albumin. That's not going to really work. It's going
especially
to
branched chain amino acids.
correct, correct. So yes, yeah. The PPT I have shared across. I think it's
Okay, we
available.
can, Jyoti, can you just share it? If you are okay, then we can share it, sir.
Yes, sure, ma'am. We will just check, take the permission from doctor. Once he
Yes.
approve, then we
I have
can
no
share
issues.
it.
Please share it. No issues.
Okay, done, sir. Thank you, sir.
Uh,
Well,
when
there's one
patient is
more
on
question.
CKD and DCLD, not on dialysis, how much protein to give? Good question again. I think over here the cutoff. See, actually the nephrologist I believe in 1 to 1.2 grams. So we with over here what we do is we follow 1.2 gram per kg in these patients.
Is there any questions?
I think so. No more questions, ma'am.
Okay.
Yeah. Ma'am,
We
we can
can
close.
conclude. Yes,
Yeah,
can we
we can
conclude?
just have the thank you to Dr. Conclude.
Okay.
Yeah.
Thank you, Dr. Karthik. It's really wonderful session today. We had a very highlights on nutrition as a cornerstone of liver disease management rather than adjunct to the medical therapy. Early nutritional assessment, adequate calorie and protein intake, prevention of sarcopenia, individualized dietary counseling, and nutrition management can significantly improve the patient outcome. Thank you to our Dr. Karthik today for giving a wonderful session and excellent presentation to the audience and your thoughtful participation for all the participants. Thank you, sir. Thank you.
Thank you very much, ma'am.
And
Thank you for
thank
the
you,
team and the
Jyoti, for
audience.
organizing such a wonderful session today, and the most important session on liver disease, and definitely the
Yes,
most
ma'am.
required sessions actually.
Yes, actually, July is a World Hepatitis Day, so we are
Yes.
going with the flow of the medical days, ma'am. Yeah.
Thank you so much. Thank
Thank you.
you,
Thank
Thank
you.
you very
Jyoti.
much.
Thank
Thank you,
you,
Thank you,
Dr.
Karthik.
sir. Thank you so much. I would also like to thanks to Eastman once again for giving an opportunity and to be associated with Hexagon Nutrition. Once again, thank you everyone, all the participants. We'll look forward for the next upcoming session, next one. Thank you, everyone.
Thank you very much. Thank you.
Thank you.
Thank you.
Thank you,
Thank you.
Ispen team and Hexagon Nutrition team. Thank you.
Thank you.